I agree with your point, sir. I think this is the last talk. I'll try to finish faster and then we can have discussion for 5 minutes. Also, we have UVA expert Dr. Kalpana here. A little bit about how you mix and match the retina and the UVA training. Because when they choose for retina practice and many UVA patients starts coming up, and how much do they really need to get exposed, especially to the UVA practice. I think I want you to just answer a minute on that. So I think the Anand sir has covered all the topics of all the 4 speakers, so I don't have to really, but it's good thing to have the talk at the end so that you will get speakers and the audience from the next session also. That's the advantage of being in. Sometimes when you try practicing in the niche specialty like retina, it's always the thing. So the perspective here of the talk is both, because when me and Dr. Chitra were discussing about this, so it directs both to the teachers as well as, that is the trainers as well as the fellows, both together. So the basic expectations of the fellows, I think we all discussed about it. But they should be able to manage a patient. That's how is most important, rather than kitne kaatne ko milega, kitna chances milega, kitna surgery milega. Should get chances to learn new skills and hone the existing one. Get a chance to be a part of the research activities and should know their competent levels and their limitations, understanding their needs. The personalization what I suggest is, because sometimes the fellows become a liability. That's my another question to the panelists after this talk, that do you have any of the kind of rubrics or anything where after 3 months you get to know that the fellow is not performing well, who did extremely well and he gave the best impression during the interview and unfortunately not performing well. So how do you go with that fellow? You try to terminate him, or you try to give an extra coaching, try to hone him, I think is the question. I request the panelists also to answer for that. That's because sometimes they become a liability and they speak very unruly behavior with the patient. So how are you going to deal with those fellows? So it's always better to plan them accordingly, sit with them, talk to them, and try to find out of the box, out of the session, or out of the clinical environment, what's going on. And in those cases, I think can plan the fellowship that is based on their competencies. So the work atmosphere, it was the interesting paper. Here you can see the consequence of work environment on employees. It was published in the Indian Journal of Business and Management. Behavioral component of the office environment have a greater effect on productivity than the physical components alone. So, and satisfaction of the employees towards overall workplace environment leads to productivity. I think having a better work environment for the fellows is definitely important. The must and do's for your specialty is definitely what the fellows needs to know about it, the good to knows, the once in a while. And when you are starting your practice, I suggest all my fellows that don't do a complex cases like PDR or stage 4, stage 5 ROPs or complex retinal detachment, because any of these recurrences might always not give a good name when they especially do a standalone retina centers when they try to put it up. The symbiotic association, that is both the planner and the students should know their responsibilities and the reasonable expectations. In the training, the interesting thing I found out was the Dreyfus model of being how you start from the novice, the advanced beginner, competent, proficient. This is how the Dreyfus model of skill acquisition is based on. The novice, unconsciously incompetent, where you do not know that you don't know how you to do something. Then becomes an advanced beginner, consciously incompetent. That means you don't know how to do something, but that keeps bothering you how to do that. That's basically, these things can be taught by the surgical seniors, surgical residents whom you are following or mentoring with, or the senior resident or the senior fellow can definitely bring them out from this category and then put them in the competent section where you become consciously competent. That is remediation by the faculty, the senior faculty, where they comes into the play and that then try to modify you, and then finally you become an expert and then go off from the institution. So the lacunae is the lack of explicit competency-based assessment. In India, in most of these curriculum, we don't have this, focusing more on theory rather than competency and ignoring the attitude and the communication part. I think Dr. Anand rightly spoke about the attitude and aptitude. So what's the traditional model most of us will still follow during a residency? Curriculum drives it. Curriculum drives the educational objectives and the assessment. However, the most important now we need to look into is the competency-based educational models. That is where the health needs, what the health system needs. the competency outcome assessment, that should probably, it drives the curriculum and not the curriculum driving it. So the attitude and aptitude, I think he has already mentioned about it, but this is about the ACGME current assessment system, how it's going on, the system-based practice, professionalism, what is being taught about, interpersonal and communication skill, practice-based learning, patient care, and medical knowledge. I think these all have been already covered about the knowledge, the OSCEs, there are seminars, symposiums, there are various exams being given, FRCS, FICO, FAICO, skill-based, that's the ICO rubrics. If your fellows can definitely go into the ICO site and try to check your skills through the ICO rubrics. Attitude, I'll come to that, the professionalism, and the overall competence, that is ICO 360-degree assessment tool. So this is again available in the website, ICO 360-degree assessment tool, where we can check it. And simulation model, definitely wet lab, dry lab, mannequin, computer-driven, even help me see in ISM SICS Society, we have started that huge machine. Although it's expensive, you can definitely go in once in a while, drive to Mumbai and try to do how the cataract surgeries are being done, help with the electronic simulators. We have the slots for that, so we can give you. Before you touch on the human eyes, I think it's better to do that. And of course, virtual reality is definitely what we have learned through this difficult COVID times. This is another thing, is the evidence for effectiveness of the simulation is based on the Kirkpatrick's 4-level of education values. So the most important I would like to touch upon is, you all must be knowing about the George Miller. The George Miller is the Miller's assessment of pyramid. He explained us why professionalism has to be included in the medical education. The practice of medicine is an art, not a trade or business. It's a calling in which your heart will be equally exercised with your head. It's now agreed that professionalism must also be taught besides being caught. So what does this professionalism? Professionalism means only speaking good to your patients or improving your communication skills? No. It amounts for accountability. We have to be accountable for our patients. Altruism, excellence, humanism, sound understanding of ethics, good communication skills, and of course, the clinical competency. This all structures the professionalism. And why we need to assess the core competency? The reason for assessing professionalism is to determine whether medical learners acquire and practicing physicians have, because medical learners will attempt to master a subject only if they know that they are being assessed. And that's what it says. Assessment always drives learning. So we need to know the fellows, even the senior most has to be assessed by somebody. Then only we have that the will to drive, to go, yes, I have to do correct. If I don't come on time, then they will not come on time. Who is going to inspect me? If I am so the rules from the watchman to chairman, what these business management people speak about, I think that should apply in most of the institutions. It has to be, because they don't respect what you expect, they respect what you inspect. So studies from the West have shown that students demonstrating unprofessional behavior during their undergraduate or postgraduate are more likely to be found guilty. Because the Medical Council of India, I think they have now included this professionalism, but until all these years, we were lacking behind from the Western studies, where the professionalism was definitely taught as a different subject. So the assessment during the medical education and training, self-assessment, peer-based assessment. Ask your fellows, how did I do the vitrectomy today? How did I do the buckle today? Did my hand shake? Did I put a buckle well? Did I make any difficulty in placing the suture under the buckle? So all these, I think your fellows, your sisters, your colleagues, who are nurse assistants, you should ask them. You should have kind of rapport with them. I think that will definitely drive you. And new approaches to social media. This is very, very important, because I have seen many of the fellows, not just retina, see any interesting patient, we put it up in the Facebook. Wow, what a fantastic patient I had. Having a sub-ILM bleed, I saw it, one of our fellows posting it up, and I said, just remove it. Sub-ILM bleed in a patient it must be how you treated it is fantastic to you, but not to the patient. Let's look into this video. No sound. It's okay. So this is happened in University of Columbia, where the nurses, the assisting nurses, the assisting surgeons were all dancing. You know, the patient is being taken for some 8 hours to 10 hours of spine surgery. And then you see the painting on the back. And this was unfortunately put it up in one of the social media. You know what happened? They lost their jobs. losing jobs in the Western countries, it's very difficult to get it back. So whenever we are posting on the social media, especially to our postgraduates and the fellows who are very enthusiastic of doing wonderful surgeries, we understand it, but not the local public. So I think we need to have some ethics in posting up in the social media as well. That's also a very important point. So again, I think drawing the charts, this is a study holiday, how I used to do it, set up a timetable, practical, 2-hour principle, and mocking it up in the exams. Now coming to the few more parts is about the fellowship abroad. Many students keep asking about it. Sir, after fellowship, should I go abroad? Should it better? Definitely, first I always suggest is to have an Indian fellowship. And having a Western fellowship abroad, either in the Asian or the Western, you get the taste of the different surgeons, how they do about it, how they look about it, how they try to handle the patients, what is the interpersonal communication skills, how they deal with the patient, how they touch the patient. So all these things I think will definitely be improved. You have definitely various fellowships programs available, short-term fellowship, long-term fellowship. And I always say that before you do a long-term fellowship, have an observership, that is the dipstick test, I would like to call it. And definitely try to join these voluntary organizations like Orbis or anything where they try to bring you up and you go to different countries, you get a good exposure before you want to start your own. So International Council of Ophthalmology Fellowships are also there, ICO, rubrics and all. And another important thing I request you all is to do some other specialty courses also. You should know how to manage your finance, how to do a good human, how to be a good human resource manager. You need to hire, you need to take people inside, you need to run the hospital, run the show, and all those things. I think doing a hospital management course is definitely not a wrong idea. Choosing the right path, again, you have to, one thing, answer to this all questions, whether you want to join institution, private practice, medical, solo, all this, please ask your mentors. They are your best guides. They have seen you for all these years, they know how you are, they know how you are going to do further. So just close your eyes and ask your mentors. I think they'll be the best people, best teachers to suggest you what you should do further. So I think with this, I'll come to the end. Last point, patientology. The many physicians are unaware of the behavioral and psychological aspects of the patients because of an absence of systematic program that translate the physician's interest in patients into the actual practice of medicine. The newly designed designated field, which might be called as the patientology. Unfortunately, again, these skills are never taught formally in our medical colleges. Some doctors have great bedside manner because they have high emotional quotient. So who are patientologists? Empathetic, who can understand what the patient's fears and worries are so that they can help to manage them. One way all doctors can become better patientologists is by teaching their patients how to become better patients. Right? So the good patients make for good doctors, and it's possible to provide patients with a toolbox of skills which they can help to learn themselves. So finally, find a right balance, friends, course, eating, exercise, sleep, work, family, all these are definitely important. Not just doing the ILM peeling, kitna acha ye kiya, itna acha wo kiya. Oh, of course, that's good. But also finding a good work-life balance is very important. And lastly, I would like to end this slide. During the press conference, he's the Steve Ballmer, the chief of the Nokia company. He said, we didn't do anything wrong, but somehow we lost. And when the analysts analyzed that, they found out they missed out on learning, they missed out on changing, they lost their chance of survival. So what's the moral of the story? If we don't change, we shall be removed from the competition. So one advice to all our young ophthalmologists, young budding ophthalmologists, keep changing yourself, keep innovating yourself. Thank you very much for the patiently.